All right, hopefully you all enjoyed your lunch. And so now we're going to do some panel discussions. This is what we did this agenda type last year, and I think it went over well. We have 3 different topics we're going to talk with. Yeah, so Dr. Delaney, if you want to come on up too. And have a seat with them. That's all right. So this panel discussion is going to be on substance use trends among seniors, and we have Dr. Mark Stavros with us today as the moderator. I'm going to give him this mic here in a minute. He is another one of our peer prescriber mentors. He's very passionate, especially on the jail side of things, of getting treatment to individuals who are incarcerated. That's one of his big topics, like Dr. Hunt's pregnancy. But we're going to start off with each one of the panelists, not Dr. Delaney, but he can talk about some of his work too, but have each one of the individuals up here talk about their work that they're doing with in their clients who are considered seniors and how those are going. And then Dr. Stavros has some questions for them, but we hope that those questions will prompt your questions. So this session's about 45 minutes, and then we'll go to the next one. So I'm going to turn this mic over to Dr. Stavros.
Good.
Yes.
All right. How's everybody doing? Y'all eat? You get some of that dessert?
No.
Who ate the brownie? Who had the cookie? Who had both? Oh, come on now. All right. Yeah. All right, but so we're going to go ahead. I really want participation from the audience here. If I have to stimulate questions, I have a handout here that I can ask questions. But we're going to go ahead and everybody kind of briefly talk about what they're doing first, as Diana had mentioned, and then we'll go ask questions afterwards. So who wants to volunteer to go first up there? Thank you, Dr. Hunt. Oh, you didn't raise your hand. I just could have seen that. Okay.
What do you want me to do?
I have no idea. Just talk about kind of what you've been doing in regards to, I think our first thing we're going to be talking about is screening, medication, and other treatments.
No, that's right.
All right, that's the wrong one. So we're going to go to
Well, talking about seniors,
Right.
kind of experience treating baby boomers. I kind of give a talk on baby boomers and opiate use disorder, which has kind of been fascinating to see that increase along with opiate use disorder in the general population, and even now, so even more. If you look at it kind of prorated to the size, they're more and more, like Dr. Delaney said, higher risk of overdose in that population for numerous reasons that he even talked about. But I've seen the seniors that come to mind that I've treated either at the University of Florida or at our treatment center at Recovery Keys is a lot come in. Alcohol is still number one, hands down. And then with all those added complications of it's easier for them to get medications as they get older. A lot of times they have a therapeutic alliance with their doctor who doesn't think they're going to have a problem. So sleeping pills when they're having trouble sleeping, and then obviously mixed with any of their other. So as they get older, even on pain medicine or say benzos or sleeping pills, they can almost overdose on a therapeutic or a dose that's prescribed from their doctor as they get older. And then you throw alcohol in on it, that's usually kind of what tips them over the edge that enters into the treatment. So I see most with either the benzodiazepines that have gotten out of control, and really they haven't had to even abuse them to a certain degree or misuse them. Even at the regular doses, they start to have a lot of cognitive. We talked about dementia. We treat a lot of healthcare professionals at the University of Florida, so I've treated a lot of doctors that just with the benzo alone failed their neurocognitive testing to the point where they wouldn't be allowed to go back to practice at all. In 90 days, 6 months later, they retake just off the benzos and they ace it. So it's amazing the damage that these medications, then you throw alcohol, fuel on the fire, it's even more complicated. I don't know if that answered your question, but it's kind of, I thought how I'd answer it.
I'll be like Donahue.
Hello, good afternoon. Since you're encouraging questions, my name is Angie Buckley and I work at Aspire Health Partners. What do you see, one of the trends that we're seeing lately with our elderly is the use of vitamins and the non-prescribed medications that they use, herbs and things like that. We are seeing an increase of those. Kratom, believe it or not. So what do you suggest doing in that circumstance? What are some tips? What are some things that we can do? There is no education out there other than, of course, substance abuse education and teaching them about medication and things like that. But anything specific? Have you guys noticed that? Have you seen any of that?
Well, it's funny. I've just seen it, and I'll turn it over to my panelists. I think I'm talking too much. But the older patients that come in there in Jackson Beach area, Ponte Beach, they all come in with bags full of over-the-counter supplements and herbs that I've never heard of. I've had to start educating myself on all that. Most of the time, since it's residential, we just stop it all and then look at it and try to learn about what it is. But it's, like I said, I'm just now starting to see a ton of that as well. And I think that's pretty common in the population. A lot of people have gone to holistic approaches. It's been a push in it. So not only in our seniors, a lot of people are taking medications or herbal supplements and things like that. But I'll let these guys go.
I think you just...
I don't want to beat a dead horse. I think it's just important for that integrated care with primary care. We always send our seniors back and say, this is a wonderful conversation to have with your primary care physician. Let's talk about the risks and benefits. That's really loud. I'm sorry.
Probably a full 2 to go. Just bring it closer to you and they will stop turning it up.
Yeah, one of the things that, again, it all comes back to, being comfortable asking questions, but supplements are becoming a real problem. And in a lot, not just in the older adult, but in a lot of populations, because the other thing is that if one is good, maybe 3 is better. And you really don't know how many they're taking. And I will tell you the newer thing that I'm running into, just with a couple of my clients, it only found out because I had a problem and ended up in the ER, and I have a very small private practice. They're going and getting kratom. Yeah. I got depression, I'll go get kratom. And some of these places aren't what I would call really good because they don't ask them what other medications they're on. I've got a person who's bipolar and went and got kratom, and they didn't even ask if she was on bipolar medications. And then I got a call from the ER saying she's had a psychotic break. And it's not just supplements, it's these other kind of areas that are being touted as, saves people. And I'm not sure that that's good. But again, it's supplements are really, I worked with a woman who was on 6 different supplements. So that's what from that.
And they're not going to their physician for prayer. Right. They're not going to healthcare.
No, they're going to
Right. So there is, I think there's also you can distinguish also, we talk about older adults. I think we think of older adults sometimes as, well, first of all, I did, there's the kind of throwaway we don't think about at all. But I think that we sometimes think about an older adult as one big day. And the different what I found is, if you talk about the baby boomers, man, treating baby boomers, here to treating that World War II generation is vastly different. And the way they make decisions about who they're going to listen to and whether they're going to listen to the physician. If World War II generation, your 70s and plus patient is going to see the degrees on your wall and say, you're the doctor, you tell me what to do. That baby boomer is going to say, F you, I know 10 other doctors with better cars than you and more books. And so they're far more likely. So I see that. But I especially see it with the baby boomer generation. I don't know if you see a difference, but with the baby boomer generation, it's far more likely to say, you know what, that guy, my grandkid showed me an expert on TikTok, and I like what he says better, and I'm going to listen to him and not you. So I think there's also that the generational cohort is different in who they're going to listen to. All right, another question here.
Yeah, I was just going to reinforce a few things that were just said, and I appreciate it. Dr. Dybin, I believe, as I said. Okay. But you just, ironically, I was already going to say this, and you just referenced it, which I think was really great, that it's almost this euphoric speech that we see across culture now, especially with, ironically, with younger generations, but those younger generations are then going to the older generation and saying, have you seen this? It's amazing. And that people they trust, their grandkids or child or whatever, is going to tell them like, hey, have you seen this thing that you can get at the grocery store or gas station? It so-and-so says it does this great thing for them. I used it for me and it did this great thing for me. Frankly, why wouldn't I try that if I'm also having that same issue, especially when speech nowadays is so strong in this thing that provides me maybe potentially some relief for me. Well, it does amazing things for me now all of a sudden. And why wouldn't I try this thing that does amazing things for this person across the way? And I'm having that same issue. So I think that's a lot of what we're seeing with supplements and Kratom and these other items where one person says, oh my gosh, it was so great, with this almost euphoric speech.
Yeah. Thank you. I get my exercise.
I think TikTok's treatment generation of the big fat area, as it is very much prominent issues we're having where the grandkids is showing up our seniors are recommending all of those over the counter.
I'll tell you, 10 years ago, not today, you can get weed anywhere. It's pretty easy. A significant issue. But 10, 15 years ago, when I'd have 4 adults, I've been working in older adult specific residential treatment for over 20 years. 15 years ago, people would say, what, older adults are smoking weed? Where are they getting it? I will tell you that it was almost always from their grandkids. Not anymore. Now everybody can get the access, and so, but it was almost always from the grandkids.
Well, you were talking about also this reliance on, oh, you have a degree. Well, the fact that they can go to a doctor now and get their medical marijuana card, so it's a prescription. It's also that generation.
Absolutely.
It's actually kind of a flip. When I was collecting data for the nation, what we saw is most young people who got into prescription opioids stolen from their parents' cabinet or from their friend's cabinet. Now they're getting it from their kids.
Right.
So that's that generational shit.
So it's a little hard to hear. If you could pull those microphones just a little bit closer to yourselves, that'd be awesome. Thank you. Just a little bit in the back here. Or I am older, maybe my hearing's gone. Whoosh. All right, we have another question here. We're going to share.
Good evening. Good afternoon. I'm Jennifer with DCF. I have a question. So how are healthcare providers and community organizations adapting their approaches to identify and address substance use disorder with older adults, especially when the symptoms can be mistaken for age-related conditions?
Oh, such a great question. A couple of things that are really important from that, about that. And I think it's actually, the answer has actually been said many, 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 many times. Dr. Laney certainly said it. It is all about educating providers. So, I'm a strapping young 50-something. If I go into the ER and I have an unexplained fall, immediately you're going to be asking, what drugs have you taken? How much have you been drinking, right? My mother is still alive. She's in her 80s, and she has this perfect white hair, and she sounds like this. And if she comes into the ER with, an unexplained fall, the immediate thought, it's very likely that the questions won't even be asked. How much have you been drinking? What drugs are you on? So the education, and this is the other thing, as a non-physician, I, been do a lot of trainings with physicians. And when I first started doing that, I thought, you guys aren't going to want to hear a damn thing I have to say because I'm not a physician. And it's not true. Every professional, medical professionals, there's nurse practitioners out here, and they want to do their job. They want to do it well. So educating people to ask the questions and to not make assumptions. And by the way, that's true of psychotherapists as well. It is important that we ask those questions and that we be comfortable asking questions about drug use, about alcohol use,
And I think it's been said a lot. But I think the number one thing is educating healthcare practitioners, from the physician to the nurse to the psychotherapist, to not make assumptions, to ask the questions. And I also love something you mentioned. I think measurement-based care is something that is really important. You talked about going and you see your physician and they'll give you a GAD-7 and a PHQ-9. And we talk about, recovery capital. There are brief measures like the BARC-10 that can help measure how people are growing in recovery capital, that I think health professionals want to use. They're just not aware of. I got to shut up now.
No, that was great.
Oh, that's good. I think we're actually, here's the thing that's interesting to me. You can't really make too much of a distinction between trends and screening, medication, and other treatments, because you guys are feeding off and we're just feeding into that. Understanding what the trends are means you need to be checking out beyond your center. What does your state data look like? The biggest issue for me in terms of substance use trends is this population, a level of polypharmacy is significant, much more than because they have so many other conditions, diabetes, high cholesterol, respiratory problems. That's the big trend. And then these other drugs come in and create other problems. So that, and I look at a lot at morbidity and mortality data because I want to know who's ending up in the ER and why. So I look a lot at that to find out what the trends are, and then that gets into the next panel, which talks about what do you do differently. But to me, the biggest trend is the polypharmacy that I see every day.
I have so much going on in my head, so I'll go all over the place. So. But as a physician, I will tell you a couple of things. It is difficult sometimes to ask patients about drug use, right? And especially older population, and you have to get comfortable. I have to teach my colleagues, you have to address what medications they're taking. Is there the potential of any drug use? And the way that I like to kind of handle it sometimes is talking about the relationship they have with their medication, right? Have you ever had a bad relationship with a medication? Because if I say it differently, it's like you're calling me a drug addict. No, so we're pressured. As physicians, we're pressured sometimes because we have patient satisfaction, is the preeminent thing. We got to make everybody happy, right? Well, patient satisfaction is kind of a little bit of a misnomer, because if I have to do the right thing for you from a medical standpoint and you're unhappy, there's a disconnect there. So I have a colleague, we try to teach about, let's not give out a lot of opiate medications out of the emergency department. Oftentimes we get a lot of complaints when we don't do things like that. And it's never a complaint that they didn't give me an opiate. It's a complaint that he had bad bedside manner, right? That's the complaint you get. So it's very difficult to actually teach other physicians or healthcare providers how to do this, because the easy thing to do sometimes is just I'm just going to give it to them because I don't want to have a complaint. I'm just going to give it to them because it's just going to be so frustrating when the person gets mad at me, right? So, and we have to try to train people how to address it in a little bit better way and not be overly aggressive about that. And so I've had to try to learn a little bit about how do I address this? How do I bring it up? I talk about a relationship with that medication too. So that was a total tangent. Sorry, I don't even know that had to do anything. It was just through my head. Anybody else? Oh, we got good. Things just rolling around my head here. Go first.
Good afternoon, everyone. My name is Taiwo Emela. I work with FBHA. I do mental health and substance abuse. So just to reiterate what you just said about asking patients going further what kind of drugs they've used. In my experience, I've noticed some of them does not even realize using marijuana is part of illegal drug use. So I tend to sometimes have to list all these drugs. Have you used meth before, cocaine, marijuana, before they can eventually come out to their views in the past?
Yeah, I think if you systematically come up with some way to ask patients, sometimes I ask everybody this, and if you're going to ask an 80-year-old lady, it's I'm going to ask you this question because I ask all my patients this. It has nothing to do with you. It is all my patients get the same questions every single time. And if you bring it that way, they're like, okay, fine. They're not singling me out. You're not thinking anything about that part.
I'm just going to add to that. We spoke about that earlier, I believe, the stigma. So I don't know how much of that can be incorporated into medical practice, but that the belief that they're not going to get in trouble for saying that they do utilize certain substances or supplements or drugs, etc., because that stigma is huge with that generation as well. They don't want to be called. I had a family friend actually call me after having been prescribed opioids after a bad car accident, getting dependency, having that develop, and saying, oh, I'm not a drug addict. Kept repeating that to me over the phone over and over when looking for resources. And so having to destigmatize that so they know, okay, we'll talk to your doctor about how you're feeling. Maybe the dose you're receiving is not what you need, or maybe there are alternatives. So I know we talk a lot about ACEs as well, adverse childhood experiences, but also, adult adverse experiences as well that can be screened for, not making the doctor step out of their role as a primary care physician, but just kind of screening for those factors.
One of the very first things, so the older adult program came out of Hazelden, actually. So where I am now was a Hazelden program back in the 80s, and there was a really cranky clinical director who realized that older adults, who every once in a while we'd have on the men's and women's program, they would they'd go through treatment, but either they would be like, I don't relate to any of you kids, so I'm just going to sit back. I'm not going to say anything. I'm going to be the perfect patient. And they would go through treatment, do no work on themselves, get out and just go drink or do whatever. Or they would become the uncle or the aunt or the grandparent of the group, and they would take care of everybody and do nothing for themselves. So this cranky old, God love her. I called her that when we had that great relationship when she was alive. But she created this older adult program. And one of the very first things, especially coming out, if you're familiar with Hazelden, very 12-step based, very traditional, very important to say things like, hi, I'm John, I'm an alcoholic, or hi, I'm John and I'm an addict. And what they found out really, really quickly was there was a tremendous resistance to that in the older adult program, because they know what an addict is. They know what an alcoholic is. It's the guy living under the bridge, right, who's going to rob you, and it can't be me. And one of the very first things that was radical at the time for a Hazelden-based program is, if you want to get better and you're like doing stuff and you can call yourself whatever you want. You don't have to, the dropping that saying, you don't have to call yourself an alcoholic. You don't have to use that term. And for some people, even today, like that, they would say, I need those things. I need those labels for me. That works for me, and it's life-saving for me, and I honor that. But in our older adult program, I'll tell you, that was one of the first things that we changed. And that's, I think, the key is looking and really getting to know this population. What works, what helps them, and what doesn't. And that which doesn't, let's be data over dogma. So if it doesn't help them, if that creates a barrier, saying you don't have to say you're an alcoholic and you don't have to say you're an addict. I'm not going to tell you you're in denial, because you won't say those things when you're doing the things that are helping you live.
Yeah, I agree. And I even go one step further. I even beat them to the punch. I know you're not an alcoholic. I know you're not an addict, but I 100% guarantee you have an alcohol use disorder moderate or an alcohol use disorder severe, talking about using the medical terminology. And then once they get into the rooms, get into recovery, they can determine if they want to use that terminology or not. But definitely, you have a stimulant use disorder. You're not a crackhead. You got a stimulant use disorder. You're not a cocaine addict. Use the medical terms. I think with that, especially that generation, it helps them see. And then now that we've medicalized more treatment with the kind of a medical model, whatever you want to call it, but addiction medicine physicians, more clinical based, medicine based, medical doctor. Sometimes with that population, that helps as well, even though the majority of obviously the counseling is done by the therapist and things like that. But having more of a medical reference to it sometimes helps that generation.
Also, the assessment process, just utilizing more delicate terminology. Have you ever had an issue with overuse or misuse of your medications, or have you ever had a reliance on alcohol to help you sleep and those types of things while you're building that relationship. If you come out hot out the gate with, have you ever had an alcohol use disorder, an addiction, then they shut down that entire population. It's still overcoming that stigma themselves.
I have to tell one funny story. So one of the most recent patients we had was in his 80s, very successful, retired, 30 years in recovery from alcohol use disorder, but over the last several years have been prescribed benzodiazepines, and was starting to have significant memory issues, was able to taper down quite a bit, basically down to 0.25 of Klonopin twice a day, and tried to stop on his own and actually wanted to come into detox treatment for that last bit. And, if you really did the DSM-5, he's maybe, sedative use disorder, moderate, maybe even mild. But the funny thing was, does he really even need it? Types of thing. Of course, he's going to benefit from it regardless. And so I get his Klonopin prescription and I count him, and he's off by 3 from what he told me. And I said, "Where's the other 3?" He said, "Well, I was coming in this morning. I thought I'd take them all." I said, "Well, you belong."
I want to pick up on a couple of points that actually, so for example, you brought up the point, this is reaching back when I was in the hospital working. People were coming in for treatment for benzodiazepine treatment, and they had followed the rules. And, that was when we really didn't know there was a really long half-life with a lot of benzos. And then they stopped, and all of a sudden they're drinking copious amounts of alcohol. And, we really didn't think about that. But this is the thing, is a lot of the medications do have a long half-life. So what you said is critical about understanding trends in older adults. They follow the rules for the most part, and they don't know that they're building up tremendous tolerances. And then when they stop, they just will find something to fill the void. But the other thing that I think is a key, besides I think everything should be driven by data, but, health guy, the issue of culture is really critical. But it's not just across, like Nation has a culture. Each state has a culture, but all the communities have a culture. So thinking about what are the trends in your community, as close down as you can get to say, all right, what are the big drugs of abuse in our community? Where's the alcohol abuse? And yes, we've been focused on opioid abuse because we had so many people die. But the data I was showing you earlier is we've got people dying from alcohol-related liver disease at pretty high rates. It's still the most used drug in our society. So, I just assume people have used something. So I just say, tell me about anything you use. And I start from the say, so what medications are you on? And I just said, I like your way. It's like, well, have you had problems with any of them? But again, I try to think, like, I live in DC, which is kind of pretty high capital of mortality. And I just kind of assume that the trends are the people I'm going to see are going to be having problems. So, but I try to, based on what's going on, I try to develop my thinking about what I'm going to do based on what I see as the larger trends, and then understand whoever's in front of me is so unique. And I have to be respectful of that. They don't have the same thing that I see in the data, but at least the data gives me a place to start.
Awesome. Any other questions?
The patient I was talking about earlier was surprised when I told him that, he was taking alcohol in a pill. Never. Right?
So why do you think substance use disorders among seniors increased by 50% since 2009?
Uber.
What's that?
Uber.
This is what I ended up having to go down and talk to the staffers, and they said, why are 40-year-olds using marijuana and other things such higher rates than they did last, 10 years ago? I said, well, did you look at the 30-year-olds 10 years ago? So a lot of these people have been using drugs for a long time, and that's only one factor. But, a lot of them never stopped using. So that's one of the reasons you see a lot of the marijuana, a lot of drugs we thought people wouldn't use. But the other thing is, is that, again, I think in some cases, the over-reliance of the professions on medicating symptoms rather than treating the person. So they're getting prescribed more medications for many reasons. But, I'm a big fan of bringing people in for 2 weeks, getting them off all meds and find out which ones they need to be on. And that includes I'll be here all week. But, and that was the benefit when I worked in the public health system. We could do that for some people, but there's not enough dollars to do that anymore. But it's really, again, it'll get into the screening stuff, but there's just so much psychopharmacology out there now, and it doesn't all need to be done because we're not asking people to talk to us, we're not making the relationships, and we're not putting enough supports in the system because a lot of them are going to go out and they're going to be isolated again. So those are some of the issues about the trends.
Yeah, and the sad reality is most of that's difficult to do on the outpatient basis, but if we have a patient come in on multiple, whatever it is, psychotropics or even their medical medications and drinking and whatever drugs they're using, and they go through a month or two of treatment, they leave on about 1/10 of the medications they came in on. And they feel so much better as well.
So anybody on the panel, in your experience, what is the best way to advocate for the medical profession to find the root cause of what somebody's coming in with? Because as been mentioned, a lot of times they just throw a pill at you. And so how do you almost demand what's really going on with the person holistically?
The sad reality is that, not only is there a stigma against addiction, but there's been a stigma against mental health their whole life as well. So, most of it all stems from trauma, adverse child experiences that we're finally starting to look at. And if these patients are, people talk to them and really get into their histories. But again, that's tough. A lot of these patients don't even want to open up. So it's a double-edged sword. But bottom line, I do think it's our stigma against mental health and of addiction that kind of sets us back and makes it so much difficult. And most, if not all, of these patients have significant levels of trauma. Now, everybody's trauma is different. My trauma may be different than yours. The way I handled my trauma may be different than the way your brain handled your trauma. But I would almost say anybody with addiction has some level of trauma in their either childhood past or even adulthood past.
I think to be really specific to your question about how do we advocate, I think we first of all have to be realistic that we have none of us, if we had a system of mechanics, I think about my wife and kids, they drive around on my wife's SUV, and that thing's really important. That SUV is really important because it carries the, my precious family. And if we lived in a country where our system was, if there's a problem with your car, you take it to a place, they've got 5 minutes. The mechanic's got 5 minutes to look at it and either fix it or duct tape it, and then you got to go to the next because we'd revolt. We would never, in our nation, we would never stand for a system of caring for our cars that is like the system that we have for caring for people. And so I think part of it's such a huge question, and there isn't one answer. But one thing I think is we need to take some of those values cards for ourselves as a people, as a nation, and we need to say what really are we valuing, what is important, and are we putting things in the right order? Because I don't think that there is a single answer to that, but the first part of it is I think that we have to admit and recognize where we are and recognize that we tolerate a healthcare system that we would revolt if it was a car care system.
I just want to thank you for that analogy. That story, that was awesome. Yes.
Thank you.
I wanted to clap as well because as a physician, it is just nutty. I mean, what we're kind of like, we have to just push through patients like it's nobody's business. You got to go as quick as possible for a lot of different reasons. I'm an ER doctor by trade, and good grief, we got to push people through like crazy because the waiting room's full, right? So, and it's frustrating, but you're right. We should not tolerate that. We should give a little bit more time. We talk about how do we screen more? It's like, good Lord, where would I find time to screen more? I don't have time to even do what I'm doing basically. So it can be very, very difficult for us to, but thank you for bringing that up. We have another question right here.
Thank you. I just want to ask for your thoughts or your approach on the patient with substance abuse treatment, MAT program, and continuously use the medical marijuana.
Could you repeat the question?
Patient, a substance abuse patient, and currently on the MAT program, and continuously use the medical marijuana.
We don't stipulate. There's no limitations. If they're ready to begin that process at any stage of their recovery, we capitalize on that. Does not matter even if they continue using. It's not even, kind of beyond the medication first model. It's the engagement first. Meet them where they're at and capitalize on that momentum to then hopefully move them towards the longer, more sustainable recovery where they can eventually come to that realization on their own.
Can I cycle back a little bit to the question about how do we deal with this a little bit differently? And by the way, it's not just the medical profession. They get hammered enough, but it's a lot of the professions. Yep. But if we want to change the system, we need to advocate as a profession, as a group of professionals, for a lot more research on working with the elderly population, and then push the policymakers at the local, state, and federal level to say, use that data to develop policies that will impact. And that is, we have a lot of money going into ASAM. It's not as much as it was a few years ago, but when I was downtown, we put in place a ton of money went to ASAM to train docs. But there's not a lot of money in other professions either. So I'm an academic geek, so do research, then use that research to go to your advocate at the local and state and federal level and say, here's what's going on. You need to help us by creating policies that fund good training, good treatment, and good care.
And also, if I can add on that, teaching the clients that we're working with, the patients, the individuals, to advocate for themselves, collaborating with their families and their caregivers to help them to collaborate for them, because sometimes they're attending these appointments with them. And rather than just kind of have that prescription first, we can advocate at that lower level while we are all doing our best to advocate at that state and federal level.
Yeah.
Hi there. So going back to the mechanic reference, it's not just about people revolting against their mechanics, because there's a lot of people who go out and work on their own cars. And that's the same thing with the over-the-counter medications. People will just go and self-medicate. And a lot of that has to do with, I would argue, the language that's brought to them in the doctor's office. Because a lot of the time, the older generation feels like they're being targeted because of their trauma, because of their ACEs. And they like to just scooch it under the rug. They don't want to be judged, and for them to have maybe younger generation, maybe somewhere in the middle, be able to advocate for them, like you said, on the personal level, then take it with a group of peers or case managers or somebody that actually understands on a personal level, and just take it one day at a time with them, because those community supports are not easy to obtain. So it's really important to have the advocation and use the language that makes them more comfortable so that they don't feel like they have to hide, right? And my question kind of bounces off of that one. With the medical marijuana use, I understand that you guys don't have stigma or stipulations towards that per se, but in the root of self-medication, where would you say that the language goes with medical marijuana, because there's a lot of people who do it just like Kratom or the Delta 8, what you can find at the gas stations. How does that differ in the pharmaceutical world?
Yeah, you're referring to medical marijuana in the sense of somebody on MOUD or MAT. Is that kind of the framework here? Oh. Well, like was said earlier, medications for opiate use disorder or MAT treat opiate use disorder. They're not treating cannabis use disorder, so we do need to meet them where they're at. Now, I see once they get in, treat the medication or the drug that's going to kill them first, and then we'll address those others as their brain starts to come back online from that. Now, we always talk about the pros and cons of medical marijuana. Now, don't get me started on medical marijuana, because there's no such thing as medical marijuana. It's never been medicalized, right? We got recreational, and they've thrown a tagline to it, because only two things you don't do with medications are what? Smoke them and vote on them. I got a new cancer drug coming out. Let's vote on it and see if the good citizens of Florida want to approve this one or not. But all right, that's all I'll say about that. But we approach the medical marijuana the same way we do methamphetamine use, cocaine use, benzodiazepine use, alcohol use. Get them off the fentanyl. They come in and they test negative for opiates. That's a win, no matter what else they test positive for. Now we bring up, how do we address this next addiction? What's the next problem we got? Somebody doing other substances while they're on MAT, they're going to be seen a lot more regular, right? You're not just going to send somebody out with a month if they're doing drinking on it or benzos. But the key is not abandoning them, not firing them from your clinic. They may need a higher level of care. You may need to recommend that. But the key is, like was said, meet them where they're at and continue to have that conversation with them. It's kind of like my conversation with pregnant women. They might not admit to their drug use early on, but as long as they see you're got their best interest at hand, and it's going to help them in the long run. And the more you build up that, you're seeing them an awful lot. So they may start to get more honest before that baby's born and really get some help. Same thing with the medical marijuana or somebody using other substances. They're getting seen every week, every 2 weeks, every month by an addiction physician, probably a therapist or a counselor as well. So that can constantly be brought up and addressed. And as their life gets better off the opiates, they may start to realize their life can get better off the other stuff as well. Plus, especially if they're doing the counseling and doing the mutual aid, the AA, the NA, and those things as well. So it's really keeping them in treatment and retained for as long as possible till we can make a difference. Does that help?
Well, and just to reinforce one thing, if everybody in this room, my opinion, if you had to do one thing leaving here to improve your work with older adults, I could only give you one thing: get trained on, get better in motivational interviewing. Motivational interviewing is it is not rocket science. It is absolutely, without a doubt. And I'm a family therapist. I'm an addiction therapist. I'm a narrative therapist by training. If there's any MFTs out there, that's what. But I'll tell you, I personally think if I could say one thing, get good at MI, and you'll find that you will be better able to talk to everybody, but especially that older adult, because it gives you a way of not only talking, but also thinking and being that is non-judgmental, and that is engaging, especially with those peer persons. And my work with pregnant women is pretty new, but I'm going to bet that 10 years from now, that I'll probably say the same thing about pregnant women, because you just said it, once they know, they may say, I'm not using now. But those that have a really high tendency towards, they're stigmatized, all the fingers in the world are pointing at them. Man, MI is the number one thing I could encourage everybody to get better at.
All right. Well, thank you much, panel. We're at 1:15 or shortly after, and we'll bring up our next group. We're going to excuse Dr. Diamond for this one and bring up Taylor South and leave all the rest of them up there. And then we'll bring Dr. Diamond back at after our break. So we're going to bring up Taylor South. And I know we didn't do this earlier, but Stephanie, would you like to introduce yourself? I'm sorry. and let them know what organization you're with and what your position is there quickly.
No,
Yes.
not kidding. Stephanie Brunson, Associate Director of Outpatient Services with Appalachia Center. We serve the Big Bend 8-county region, and essentially I'm currently in my role the supervisor of the outpatient therapy department, the FACT program, which is the assertive community treatment, as well as the MAP program. We've got a huge kind of integrated system up there in our county, so I feel very lucky to be able to share some of my experiences.
All right, Taylor, you want to do the same?
Yeah, Taylor South. I'm a licensed marriage and family.
Okay.
It was on. There, now it's on. Okay. Taylor South, licensed marriage and family therapist. I work with Tri-County Human Services. We serve Polk, Highlands, and Hardy counties. I oversee all of our outpatient programs, which we have 4 outpatient locations. We do MAT at all of those locations, either in person or via telehealth. I also oversee our community-based programs related to homelessness and the core programs for all 3 of those counties as well. So I know the core program was brought up earlier. That's probably the biggest thing that influences a lot of what we're talking about now too. For me, that I started overseeing about 9 months ago as well.
Okay. We know the rest of you. So
I must say, if you don't know him by now.
Well, I know Dr. Delaney wanted to talk about screening medications and the treatments as well. I know you wanted to get to that. So anything you want to start discussing about the screening, or do you want me to give you specific questions?
I guess over the years, and in my role in the federal government, I funded a lot of training programs, and I think everybody said it here is we need to learn ways to respectfully ask about that. You can ask in different ways, because I specialize in substance abuse. I kind of assume that people are coming to me because I keep referring people, although I do see a broader, I see as many people that have co-occurring disorders as not. I will tell you that 2 times that I found myself in trouble as a practitioner is I didn't require a screening, a urine or a blood screening, and I didn't require a physician checking in. I have built a kind of a network of practitioners who actually understand addiction, both medical nurse practitioners, as well as health psychologists that I can refer to because I realized a long time ago I'm not very infallible. As a matter of fact, all of us have the same thing. We often don't have enough time to talk to people. So I usually send them to see a primary care to find out what their liver functions, all the other function tests I work. I want a urine analysis or a blood analysis to see what other drugs they're on. So that's part of my whole screening package. But the 2 times I got talked into, I really don't have for some reason, automatic, well, he looks really sincere. And then I found out he's smoking like a lot. And I found out because he was in the ER for a psychotic break. So I've learned to trust that if they're not, they'll show up in the testing. But it's I like Dr. Diamond's statement. If you do nothing else, if you use MI, get better at it. If you don't use MI, get good at it. Because that's the way, because when we're dealing in substance use and screening, we're really dealing with ambivalences. People may understand somewhere down there that they need some help, but especially among older people who don't compare in. So, I just assume because of what I do that people have used substances or are using substances or may, and I like what you say, like sometimes tell me about what medications you're on with your doctor and have you had trouble with it? So it's really, and like you said, got to get used to it. And I've done it for enough time now that very little scares me about and if I've had them walk out and never come back, and that's like, okay, maybe they'll be back later. And that's what in my training program, that's what we're teaching people. Get used to asking the question and find out ways. The other thing is, I don't take notes for the first half hour of an intake assessment. I just sit down and they said, I'm going to have you do paper later, guys. And you'll fill out the normal paperwork, what you did, what you had. Just tell me about yourself. Tell me what you need me to know so that I am the best help, because you are your own expert. And you're going to pay me for my time, and you're going to pay me for my skill. But you have the expertise to offer our working relationship. So in about a half an hour in, I get them to fill out the releases and all that kind of stuff. But not until I think that I've established enough of a rapport. And sometimes I don't even do that until day 2. So that's how I do. By the way, anybody use a genogram? I do a 3-level genogram with every single patient, whether they're there for anxiety. And I say, well, tell me about anybody get in trouble with, with the law, with drugs, with alcohol. Anybody really particularly anxious? Anybody seem depressed? Did you have any suicides in your family? And by the end of it, often they've kind of done this 3-level genogram where it skipped a generation, but alcohol was in the previous, or their kids are having problems. And it's a really good graphic. So Monica McGoldrick had a book on just doing genograms, and she's amazing. So that's the other stuff. I'm not, they can fill out all the forms they want. I just need to know information.
Can I go a step further?
Yep.
Is it on? Okay.
Yep.
If I could go a step further on what he said a little bit there too, that I really, really like. When you're doing a genogram with a client and they say, my grandfather had an issue with alcohol, and they see your reaction to that, and then you get to them, what's your relationship with alcohol? Which I really like that wording of relationship with.
That's her.
Yeah, I really like that. What's your relationship with this like? Because you have one. It's either totally non-existent, partially existent, totally, there is one somewhere in that. And so having that conversation, but how you responded to them telling you their grandfather had, drank heavily, that influences what their likelihood of sharing that with you 30 minutes later is. And I think that's crucial to don't miss the opportunity to show them that this is a non-judgmental space for you to say what's totally going on with you or anybody else, so that then I can step into that. Last thing I'll add that I had been thinking through as we had previous, conversations earlier is don't think that the first time you ask a question, the person's going to hear it. I know Dr. Dybin mentioned MFTs. I'm an MFT as well, and I'm trained heavily in EFT. And Dr. Sue Johnson, when she was training heavily, I was trained with her for a bit, and she would mention you have to have at least 3 to 5 flybys. And for anybody who's into aviation, a flyby is just kind of a quick thing or a touchdown. You just touch and go. And slowly you stay on the ground a little bit more on that question. And usually about the 3rd to 5th time, they'll actually hear the question you're asking and actually answer it. Because again, in the same way, don't become so confident that you know the way to word this question so the person hears it and gets it. Because we've talked about medical marijuana. If I ask about medications, some people will answer that yes. Some people will be like, nope, none. And then they're like, oh, I didn't get you my medical marijuana card. And I go, are you using that? Well, yeah. That came up nowhere when I asked about medications, but it's a medical marijuana card. But then I asked if you use other substances, and you said no to all of those things. So I missed it somewhere, or you missed it somewhere, but I asked a question that I thought you fully understood. There was some disconnect there. So asking the same question, maybe even just slightly different, 3 to 5 times. In couples therapy, it works wonders. You'll ask the same question, and both partners will hear totally different things. And it works the same way here when you're doing a screening.
I think you guys bring up some really good points about you're establishing a relationship with that patient, and you have to get their trust. You have to get their trust, right? And I think the way that you approach it really makes a difference. And even in like drug screens, right? There's an approach to this. This is not I'm going to do a drug screen to see what you're not telling me, the gotcha moment, as opposed to just saying we're doing a drug screen because I want to be more holistic to make sure that we're treating every aspect of everything here. It's the way that you kind of approach it, right? We're using it as a tool. We're not doing this as a gotcha moment type of thing. And I think once you establish that makes a big difference. And it kind of goes back to another thought that was rolling through my head as well from the last talk, is we've lost trust in the medical system. And a lot of it is the fact that what was talked about, like with the mechanic, you got 5 minutes, right? Do you trust the healthcare system? I mean, I think we've lost a lot of trust in a lot of regards. I have. If I go to my doctor, it's very fast, in and out. I'm like, we really haven't talked about all the things I want to talk about here because you got another appointment and we got to keep moving on. So I leave kind of like, okay, I kind of feel cheated a little bit. So, but anyway, any other
I'll respond really one statement, which would just be, if you can't trust the system, at least it's my job to make sure you can trust me.
There you go. Good.
And I've said that dozens and dozens of times. I'd say roughly 80% of our referrals are, somebody said it earlier, nudged by a judge or by the Department of Children and Families or something to that effect. And so they're not necessarily there under their own free will, or they perceive it that way. And so a lot of times I will say, hey, you probably do have that stuff going on. That has little to nothing to do with me. My job is to make sure that you understand I'm literally just here for your best interest.
Great.
I have an anecdote because I used to do a lot of DWI.
Mm-hmm.
And the guy, I'd be doing the intake and doing my spiel, like, just tell me what's going on. I said, man, I don't want to be here. I said, sometimes I really don't want to be here either. He says, well, judge said I had to be here. And I said, well, you actually didn't. You could have taken the 90 days in jail. Instead, you picked 9 months with me. So you took an option. You do have choices. You do not need to be here. However, since you chose to be here, what can we work on to make sure that you don't go back in front of that judge? So I mean, that's another part of the screening and assessment, is giving them options. By the way, I also tell them, at least in my private practice, I said, we're going to do 2 sessions just to see if we fit. And we'll get some information, and at the end of it, we'll talk about what you want and how we work together. But there's going to be no harm, no foul. If you say, you seem like a nice guy, but I got nothing with you, guy. And I've had that happen. And, that's the other thing we got to be used to. Sometimes we're in the position where, we're the only game in town, kids. But in that case, if you're in a setting, then say, well, maybe my colleague John or my colleague Mary down 2 doors down probably would fit with you better. We have to give up our ego because, it's a good. By the way, if you come up to my training program, you're going to hear a lot of this crap.
Yeah, I love that. The way I look at it too, voluntary treatment's an oxymoron. We all enter treatment for the same reasons. Back problems. Somebody's on our back. Spouse, husband, DEA, judge.
Any questions out there? Did they answer everything?
Don't wake up at 12. Figure I should have asked that.
All right.
Good afternoon again, everyone. So my question is, how should screening protocols for substance use in older adults balance early detection with risk like overdiagnosing and stigma in patient rights?
Do you have 2 hours?
Well, most of it's funny we're talking about screening coming from a doctor or hospital, or a lot of our patients even recently showed up because they had a routine lab exams that showed elevated liver enzymes. That was the only reason that the substance was even, the subject was even brought up of, do they drink too much? And it kind of goes to my point before. You have a respected doctor, therapist, nurse practitioner, somebody you trust, and they bring up concern, people will seek help. If it's the problem we wait too long is when access to treatment becomes far more costly and much harder to treat, when the disease is at the severe substance use disorder or severe alcohol use disorder stage than earlier. As far as patient rights and advocacy, even with pregnant patients, the screening, when we talk about drugs or substance use disorder screening or addiction screening, it's all questionnaires for the most part. You have to get their consent to do a drug test. Now, the thing with the pregnant woman, the baby's going to get tested no matter what. So that can cause some problems down the line for the mother. So most of the time, if you can avoid the stigma and the stigma she's been taught, the stigma she's experienced, we can get them to agree to more, maybe urine testing or just being more open and honest. But the way I look at it, for the most part, now I specifically treat addiction, so most people coming to me are pretty open about it. Now, somebody that's seeing a practitioner it's not necessarily an addiction counselor or addiction physician. It really comes down to, them signing a consent to do that. You can't really just do it on your own unless it's legally mandated. But the key is motivational interviewing, like was said, building that trust, building that therapeutic alliance, explaining the benefits, and hopefully if you see them enough to build that trust, that you'll be able to get somewhere.
I would say there's some differences depending on if it's more medical versus therapeutic. In a therapeutic sense, I will generally encourage my clinicians, we can create time to have more of this conversation. I will also say, generally, you are here for a reason. Either you wanted to be here or somebody else, some other entity thought that you needed to come here. And they may be wrong, and you may be wrong. You may not actually have an issue, and we just needed a check-in type of thing, crisis services or something to that effect. Generally, you're going to lead to more ongoing services. But for me, a lot of times with my clinicians that I'm supervising is I'll say something to the effect of, I'll say to a client or person served in our cases, I'll say, what's the harm in meeting a few more times and just making sure this isn't that? You may not have an issue with alcohol, but like, what's the harm in us meeting 2-3 times and making sure? Wouldn't you rather do that? A car sales tactic. You can't make a decision without all the information. So how about we make sure you have all the information? How about we meet a few more times? This is what I do. You mentioned earlier that, you may not have an issue, but you meet the criteria for a substance use disorder. You meet the criteria for alcohol use disorder moderate. And so because of that, I'd like to meet with you at least 3-4 more times. Let's get on the same page about that. I remember a case of a mother who had an open DCF case, and all that happened was her and her daughter were making, like literally baking, and she had a glass of wine, and she slipped because they had mopped after baking, and she slipped and hit her head. Her daughter appropriately called 911, the ambulance came, yada, yada, yada. But she had an open bottle of wine because she had a glass of wine that evening, and she had a previous prescription of a benzodiazepine sitting by her kitchen sink, because that's where she took her medicines in the morning. She hadn't taken that medicine in 6 months, but because that was there and because she tripped and fell, it looked sketchy. And so appropriately so, as they're supposed to, the paramedics in 911, they called in DCF. DCF opened a case. This individual happened to have an ex-paramour who wanted to get her, presumed that he wanted to cause a whole issue. And so she came in and said, listen, you may or may not have an issue. I can't tell you that today. It looks funky, and I think you can acknowledge that. And I said very honestly with her, I said, I think you could acknowledge if this wasn't you and I told you this story, you'd say, oh, I don't know if that lady's telling the truth or not. And I don't know whether you are either. But here's what I do know. You seem pretty mature enough and you've got things going for you. You're stable in life. That really 2 or 3 sessions, we should be able to figure this out and see, is this something we need to talk about or not? And that client did end up staying with me, did about 4 to 5 sessions, realized there really was not an issue here. Everything else lined up. And she ended up finishing. She goes, this is the best thing I could have done, because now as my ex-husband is trying to make this more of an issue, I actually have an advocate in my corner. I tell my clients all the time, I say, hey, I will advocate for you. I love baseball. I played college baseball, but I will never stand up there and look like a fool without a bat. I'm never going to step into the batter's box without a bat and be like, yep, throw me a pitch. I'm never going to do that. So in order for me to really advocate for you, you need to put the bat in my hands. You need to do your part of this conversation. And that may be attending a few more sessions. And then over those 3 sessions, if they do meet my criteria or need further treatment, I can have that conversation over more period of time saying, hey, we've spent 5, 6, 7 sessions together now. I can accurately say this as a professional in this field. I can make more of that assertion or that diagnosis.
Can I ask a question? How many of you, before you got to your current job, when you were in your graduate program or your undergraduate program, got training in substance use? Not a lot. How many got training in assessing before you got to where you are? Mm-hmm. Okay. When I worked with NASW, National Association of Social Workers, years ago, and we did a thing. Fully 80% of social workers in current practice said that they were seeing people with substance use problems, but less than 5% said they had any training in their graduate program and postgraduate. So here's my policy issue for this issue. Not only do we need to ask for research, for better research on people who are elderly who have substance use problems, we need to advocate for policies among they have the ASAM stuff, but that's not a ton of money, and it's not a lot of physicians are getting it. But I think us as a profession, across the different allied health professions, could do wonders if we pulled together and advocate that during at least one course, or actually what I'm advocating in my own program at Catholic U is that each course we have at least one session. Like if you're taking a cognitive behavioral course, one session focuses solely on its application for substance use and co-occurring disorders. If you're taking the assessment course, don't just look at DSM-3, look at how you gather data. If you're doing the child and family services, one session, I mean, we could do so much better for everybody, not just those of us who've kind of committed, if we just pull together and say, let's make sure the people who get out of the programs are ready to take on the people that they're supposed to serve. Okay, I'm off the soapbox for 5 minutes.
But you jumped to the next topic. That's okay. That's good. No, thank you. Any other questions? Do I have to go to my sheet? Okay, fine.
I want to say one thing on the talked about toxicology screening. We talked about just general screening, but toxicology screening and say pregnant women, because it's been a kind of a subject we've talked about. There's been progress made. Most states, there's mandatory reporting. If the mother reports a history of opiate addiction or is even on MAT or MOUD, they have to be reported. Now, that's not the case everywhere. There are many, many states now that they don't have to be reported. Baby can be born positive and they don't have to be reported if the mother is getting treatment. If the mother is on MAT and seeing her addiction doctor, it's lies solely in the hands of the physician. Now, if she relapses, doesn't go to treatment, doesn't follow, then they can take that step into reporting to the state. But that's starting to change. This mandatory reporting stuff is probably going to go away across the board. We're going to start treating this like a regular disease. But the key is that the mother gets treatment and stays involved in treatment and gets recovery, or then the legal does have to step in, and we know there's leverage there, and it is motivating, but it's also very stressful, and sometimes can create an undue stress that can even lead to relapse more than recovery. So just wanted to throw that in. Oh, you're fine.
Yeah, that's...
I see. All right. I am going to ask a question, but on that note, and Dr. Hunt and I have been doing this a long time, really long time, no. But it's been interesting over the last several years how we've seen positive change. I mean, we are talking about opioid use disorder. We're educating medical students. We're educating other providers as well. I'm just talking for the medical healthcare part. Excuse me. And I've seen some positive change. We have a long way to go, but at least we're starting to talk about it being a chronic disease, treating this not as a choice problem, right? There's a lot of ways that people started having unhealthy relationships with their medication where it became a misuse problem, and being able to address that a lot more. And so the fact that we're talking about MAT, MOUD, it seems to be a lot more talked about. People understand what we're talking about. That's one of the approaches that I have with patients. It's like, again, there's such a crisis going on. All these people are overdosing. Have you ever, that's where you kind of bring up maybe the medications that they're taking as well. So I appreciate all that. So the question, what resources and training are available to help family caregivers and loved ones navigate difficult conversations and support a senior's recovery journey? So more geared towards families. We talk about what resources, we have as healthcare providers, but what about family members?
Yeah, and the audience can also, if y'all have experience with how you train, educate families, anybody wants to speak up, that's completely fine. In the treatment center, we have family workshops, and we really involve the family. We get a lot of collateral from the family, that type of thing. But as far as general public policy, helping, I'll pass it on to these guys or even you.
Anybody in the audience have any ideas? In the back, do you guys?
So at the Volusia Recovery Alliance, we're privileged to offer families invitation to change. It's a group meeting that's based on science and kindness, that's evidence supported. And so it teaches the families how to better communicate with their loved one that may be using. It goes over the stages of change, and it's an ongoing group that we offer once a month. It's now virtual, so you can go to our website if you're interested in checking it out. But it's a really great program that some parents of people that have substance use disorder kind of came together and started doing. And we love it at FBHA. Thanks.
Thank you.
As we're walking over to the next few that are out there, I'll throw out really fast for Tri-County, specifically the question kind of that wasn't asked, but that I'll answer is for our teens that are in services with us, their parents get education as a component of that as well. So that more family education side, those parents then have parents, so they get some of that information on that side as well. And then just in general in the community, we're doing the same things that we mentioned already of just voicing it in the community, engaging. We have 2 specific programs within our agency that are targeted at the elderly population, going into our local elderly care centers and things along those lines, providing general information about mental health. And part of that conversation about general mental health includes substance use for us.
Hi, use CRAFT, Community Reinforcement and Family Training. Research is very good on that program. Loved ones are family members who learn the CRAFT skills, their loved ones are 7 out of 10 times more likely to go to treatment and stay in treatment. And then for the 30% whose loved one doesn't go to treatment, they have a reduction of their own stress, their own anxiety and depression. We use a licensed marriage and family therapist to co-facilitate that with a peer who has a son who's now in recovery from substance use. So we offer that to anyone in our community.
I have a comment. Hi, I'm Morgan Shell. I'm with DCF CMH office. I'm a licensed mental health counselor. And when I used to treat families, I used to refer children of alcoholics, they refer to them as alcoholics, to adult children of alcohol support groups, and that actually helped with family sessions. Yep. The education piece, it actually helped supported the family, and I had a lot of success with those therapies.
Can I ask, does this group have like a website for this? Is there a website for this forum kind of group? There will be. So, suggestion. Okay, we're currently on we're setting up a web page for our training program, and we're having a community resource page and a clinician resource page, and we're starting to curate different kinds of instruments, different kinds of programs like CRAFT, and so maybe that could do. The other thing that I find is, when you leave here, find people together from here and keep communicating, set up little work groups, and then share with that. So the more you can share what works for you, also let each other know, but not on the website, what doesn't work, but like in our practice where I work with a group, we actually have resources for families, and we've curated a number of YouTube channels that talk about parenting, talk about being a family member. So we're actually putting those on our website's page, and then that's accessible to anybody that looks on our page. So those are things that can be really helpful, and that will engage the family members in a different way, because if they can do it without coming in right away. So
I'll do this because Morgan didn't do it. Morgan has the DCF collaborative that she's working on. That's what she kind of heads up at the moment. And so she has those meetings. I believe they're currently quarterly. Mark me on that, but I believe they are. And that's a great place for what Dr. Delaney is talking about, where to interact with other providers who are doing this. I know they've talked about, and they are doing multiple trainings. I'm sure this will be one of them. It's already been mentioned in, I think, all 3 of the collaborative meetings we've had so far, that, serving this elderly population is difficult and we need more training in this area. So I'm confident those will be coming too. Last thing I'll throw out is a more unofficial way of training and information that I think a lot of clients benefit from, which is just like basic TED Talk. He mentioned things you see online, like YouTube stuff, basic TED Talks that might be from more of that elderly stance or that older aging population, so that we can understand that population better. That's part of the struggle here, right? Let's use me as a not 65-year-old clinician to try to connect with an individual who is 65 is difficult for them and for me to try to find that link and that boundary. So for me, I oftentimes will find a video that maybe is from a person that's more in their shoes and then say, hey, here's where I connected with that video. Where did you connect with that? Like, is there something I totally missed in that video that you're like, oh my goodness, that's so true, that I just missed because I'm not you and I'm not of of your age, of your space, of your culture, of any of that. Help me understand that. And I've found so many times where engaging with them in that way and saying, hey, at least for those first few sessions when we're building a relationship, help me learn a little bit about you. And then I think I can provide maybe some more information and direction for you too.
I have a quick resource, and I know DCF is part of it, but the National Child Traumatic Stress Network is an amazing resource. They have a ton of different just trainings. They have a ton of different free, open to the public, because publications have been developed with SAMHSA dollars and other dollars, and National Institute of Health dollars. But National Child Traumatic Stress Network, nctsn.org. It's an amazing resource. At Aspire Health Partners, we also utilize the ACRA, Adolescent Community Reinforcement Approach. I love that evidence-based practice. It's very useful. It's very motivational, interviewing heavy, and so it's really great. We use trauma-focused CBT as well as a great resource. And in the NCTSN, there's also a learning community blog, so that if you're a clinician and you're dealing with a scenario that you can't seem to find resources, you can post the question in the blog. And so anyone I think it's a national blog. Anybody can offer assistance or can offer ideas or tips and things like that. But it's a great resource. And NCTSN also has a child welfare toolkit. I'm a national trainer for that toolkit, where we come in and we train not only clinicians, but we also train judges, we train police officers, we train DCF caseworkers on just assessing and medication, just all the gamut, from the beginning of a case to all the way to the end, preparing for court. All of that is part of that toolkit.
You had very briefly mentioned SAMHSA. I don't know about anybody else, but I think I own the entire tip series. And by own, they're free. You can order them. They have groups, they have individuals, they do have specific population. Get the resources that you can access, where you can access it, and always work to just continuing to expand your education.
Yeah, you pretty much have to go through the National Library of Medicine now, because SAMHSA shut down most of its webpage. So I'm actually going to head back to Washington, so I'm going to miss the last talk, although I'll be here in spirit. But there's an issue, I think, that has to do with screening and your job in treatment. And it has to do with the ethical obligation of each of us to take care of ourselves. In one of my previous lives, I was a first responder with the public health response teams. And my primary job was really to treat and support responders in the field who could get overwhelmed very quickly. So if you don't have a protocol, not only for filling out forms, but if you don't have a protocol for helping each other regularly, it's not just when you're stressed out, that's a preventative measure, and that's going to make the screening, intervention, and treatment better for your clients and for yourself. Because I don't know, I'm overwhelmed all the time. I mean, I work at Catholic University, and right now we're getting our grants cut back all over the place. So I'm just stressed out. Do I have enough money next month? But that's okay. I could retire the third time, but or fourth, whatever. But being a retired service member, you got a lot of flexibility. But I got people at work. We actually meet weekly, not only to cover what we're doing, but we talk about how stressed out we are about trying to train the people we're working with and the clients we serve. So to me, that's an ethical obligation of every treatment program, that they have a protocol that's preventive. The clinicians are getting help to make sure they're doing okay. This stuff falls apart. If you're so stressed out that you're judging your clients because you're just tired, and okay, that's what I ask you to do. That if you don't have it, start a group.
Well, one other comment, and it was brought up earlier, was this is a little bit different, but since you're going back to DC, and I've spent a little bit of time in DC, and I was kind of astounded, like they actually listened to me. I was like, holy cow, you go in there, you guys have just a wealth of knowledge, right? Not only do you have an opportunity, but I really feel you have an obligation to teach the people that make decisions for our country, our state, our county. We have an obligation to go teach them because they need to learn. They need to learn what the standard of care is, what the best treatment is going to be. They have dollars to spend. They need to know where to spend those dollars and how that's going to help the most amount of people. And believe it or not, your voice actually matters when you sit down and talk in front of them. Things may change, things may not, but it is definitely not going to change unless we go help educate and talk to those people that make those decisions. So just for what it's worth. That's exactly it. 18-year-olds run our country, as we found.
Okay, there we go. One thing I'll throw out, just jumping back, and it's on this same topic, but I think it's related to also the training question that was asked a moment ago. Take advantage of people, not just here, but anywhere else. I learned this from a leadership forum I was at where they said, 3 of the individuals who had spoken, it was like a 4-day thing. On the first day or two, it said, hey, here's my information. Reach out to me if you need something or you'd like more information. And then on the 4th day, the kind of MC of the whole event was said, okay, cool. Who's reached out to one of those individuals? Because they were, top 50 people in the country for leadership, and they all gave you their information personally and privately. It was a small forum. And how many of you have reached out to one of them so far? And we all looked at each other and went, crap, we failed that test because none of us had at that point. And so I think one of the big things is don't be afraid to reach out to someone. I think here in this forum and in a variety of different areas, I know a bunch of us were at the FBHA conference 2 weeks ago as well. All of those forums have immense information put right in front of us. And when that happens, we need to then take advantage of that the days following, the weeks following, the months following, to make sure that we're taking full advantage of the experts and the people that get put in front of us, so then we can do better, so we can stay on top of our own self-care, so we can stay on top of the services we're providing. This is not an area that Tri-County, I would say, is epitomizing or even close to the top with this elderly population. It's an area we're growing in, and so even here, I'm picking up a lot of information, names and information, to make sure we do what we need to do.
All right, let's throw another question out then. What changes in medical training and screening protocols are needed to ensure substance use disorders in seniors are routinely and accurately diagnosed?
Well, we're just getting, like I mentioned before, when the American Board of Medical Specialties recognized addiction medicine as a medical specialty with the same training, the same oversight as any other specialty, pediatrics, OB/GYN, general surgery, family practice. So they're now almost 10 years into it. Like I said, there's still a big discrepancy in how it's taught or how it's trained or what's dedicated to the training. You'd say we're University of Florida, we give 3 weeks in a clerkship, 3 weeks of a psych rotation devoted strictly to addiction medicine. Some other programs may only devote 2 days. So it's just still vastly not consistent. And then now you want to divide it up into, different phases of addiction medicine, seniors. Now you've been talking more specialty, more difficulty in organizing a protocol or a curriculum to train these medical students. So again, we're in the infancy stages of it, but hopefully, as what I've noticed in my personal experience, say with the University of Florida and being in the consult service for addiction medicine, when we first started the consult service several years ago, we may hit 2 or 3 consults in a week. Now we get 8 to 15 a day in just a very short period of time, because other specialties are starting to see that addiction medicine helps with every specialty. And we're probably the only field of medicine that's involved in every specialty. There's addiction from pediatrics all the way to your most specific forms of cancer. Every specialty has it. Other than cancer, addiction medicine is probably the most ubiquitous through all of these, right? So I think just with time, just with reducing stigma, just with education, just with more and more people like yourselves being involved in that process, we're going to get there. But again, we have to remember we're barely at the embassy stages of some of this, really, and we're all on the front lines.
It really does also involve CEU training. I mean, every 2 years I have to do 6 hours ethics. I have to do 6 hours of child abuse and neglect. Now it's called something. There's another one that just got added, but it's 3 hours. So ours is like oppression in Maryland, which probably will get a name change under the current situation. But so it also has to be integrated into ongoing, because, when I was at Chapel Hill, I did a 2-hour lecture. That was all they got.
As you were saying,
and that was good back then. That was in 1990. So it's getting better. You're right. I think it's improving across the professions, but I think we have to think about, again, policies for our professions to say, what do we need? Because it really is kind of, it feels onerous at times, but I know even when I go back and I do another ethics, I feel a little bit more confident. In, like, I took an ethics course on documentation, which scared the bejeebus out of me because, I thought, I'm going to go to jail. But it made me feel more confident that I was actually doing pretty much what I was supposed to do. So that's something you can advocate, not just with medicine, but with each of the allied health professions. And it probably just needs to be thinking, here's the thing, what is it you want to have happen? Is it just people to know about it, or do you want people to be able to act on it? Right. And that's the point, It's like setting a goal. If you set a goal with a patient that they know a little bit about their addiction, that's great. But if you set a goal about a patient of, I want to have a better life, something has come up a few times, that's a totally different animal.
I can't speak much for the medical, but on the clinical side, get your CAP, get your MCAP. That was the best 100 hours of training. I started in substance abuse residential treatment 20 plus years ago, and all of those 100 hours were the most insightful and educational that they had been in a very long time. So I highly recommend everyone at that clinical piece work towards that, because it does benefit us in our treatment protocols.
All right. Well, thank you very much to the panel, and thank you for all. That's it. We're done. They cut me off. So, all right.